So good afternoon, everyone, and I think we'll be starting now. My name is Marie Glorioz Ingabire. I'm with Canada's International Development Research Centre here in Ottawa. So thank you for joining us. I know there may be some other competing interesting things to do, especially for those in the Northern Hemisphere who've been facing winter for a long time. This seems to be the best, day of summer. So thank you so much for coming. So we've heard since yesterday, the beginning of the conference, the importance of data, information, and evidence. Not any kind of data or evidence, but the one that is timely, accurate, and useful. And I cannot emphasize the importance of that, especially in the current era with some of the fake or alternative facts. And we know that that can be actually impeding some of the great progress that have been achieved recently. So in the previous session, we're talking about beyond counting. How do you also engage youth, listen to them, and have them being part of the whole process. So this session is about, data collection, but I will call it even data collection and use for empowering adolescents. And we have the pleasure of having 4 panelists. And the way we will do this, we will have each panelist, have some of them have the slides, talk about their initiative and how they've actually, during the process of data collection, data use, engaged adolescents and the impact of their initiatives. We will probably have all of them present. And at the end, hopefully have time. We will engage with you and discuss, hear from either your questions, your comments, or even if you could share also with us some of the achievements or the lessons that from the field that you thought could be actually useful to everyone. So I know we have only 45 minutes, and I think this is the only panel that has 4 panelists. So, but we'll make sure that we stay in time. So I will start first with Joshua Berman. And Joshua has an extensive experience in Southern Africa, where he spent the last 10 years. And since 2012, Josh has supported the Malawi Ministry of Health in the development of a knowledge translation platform that aimed at improving the utilization of research evidence in national health policy and practice. And since 2 years, Joshua has been based in Zomba in Malawi as the Dignitas International Research and Knowledge Translation Manager, where he oversaw the development and implementation of operations, clinical and social science research related to HIV, TB, and non-communicable diseases. And today, Joshua is going to tell us about the Dignitas International initiative on adolescent health data, highlighting some of the challenges in the field. So over to you.
Great. Thanks very much, Marie Glorioz. And maybe let me just thank IDRC for the support in forming that knowledge translation platform in Malawi. Right. Okay, so we can't talk about adolescent health in Africa without talking about the elephant in the room, HIV. We know it's the leading cause of death for adolescents in Africa, and we know that the trends are going in the wrong direction, having increased 3-fold since the year 2000. So we also know why. We know that adolescents living with HIV are much more likely than adults to default from care, to stop taking their HIV medications. We also know that older adolescents are more likely to default from care as they take on an increased, let's say, supervision of their health, or responsibility of their health. So why are adolescents dropping out of care is our next question. Maybe let me just get a show of hands in the room. How many of you have been, at one time or another, an adolescent or a teen? Yeah, okay. We've all been there. We all know the difficulties. But those difficulties are exacerbated when you're an adolescent living with HIV. Often we see adolescents living with HIV that feel shame, that are trying to hide their status from friends at school. That's a difficult time, and they need programs that target them and adequately address those needs. So Dignitas International, who I work for over the last 7 years, has really stressed a strong evaluation and an evidence-based program design since its inception in 2012. So working with the Malawi Ministry of Health and Baylor University, and knowing what we do, that adolescents are more likely to default from care, we designed this Teen Club program, especially targeted at a key population, adolescents living with HIV. It's a weekend-based program so that kids and adolescents aren't missing school, and it's a health facility-based program that offers comprehensive care. So we're not talking just HIV care, but comprehensive medical care for teens living with HIV. But importantly, it's not just a medical intervention. It's an intervention that brings HIV-positive teens together with trained facilitators, with trained medical practitioners, and gives teens a sense of belonging. It's every Saturday, and we piloted this program at Zomba Central Hospital, one of Zomba's larger clinics, now several years ago, and wanted to evaluate the heck out of this program to see if it does really have an impact. So that's where the data piece comes in. So whenever we start to look and try to evaluate our programs, not just our Teen Club program, but any program that Dignitas, together with the Malawi Ministry of Health, runs, we first look to try to use the National Monitoring and Evaluation System. Why do we do that? A couple of reasons. One, the data is already there, so let's not reinvent the wheel. If that data is being collected, let's utilize it. And two, by utilizing that national system, it strengthens it, and we're not having duplicative systems. So we first tried to target and try to find out how effective our Teen Club program is by looking at the national monitoring and evaluation data. In this case, it was difficult, and this is kind of maybe the crux of my talk, challenges from the field. It was difficult to get disaggregated data from the Ministry of Health, and all of us, I think, at this conference struggle with getting disaggregated data for adolescents. So our Teen Club program spans ages 10 to 19, and that spanned several age categories within the national system. So it was difficult for us to pinpoint the data using the national M&E system to see how effective our Teen Club program was. So we couldn't use the national system. Where do we go from there to really try to study and evaluate this, what we think was a really promising program? So we did a cheap retrospective cohort study that looked retrospectively at teens that were attending Teen Club and compared those to teens that had not yet had access to a Teen Club. And we found that teens that have not had access were 3 times more likely to be lost to follow-up. And that's the key intervention's aim, is to really keep teens in care. Because if we can keep them in care, we can keep them on treatment, we can keep them alive. So that was a really promising finding, 3 times more or less likely to drop out of care. But we know that a retrospective study has limitations. And the biggest limitation is self-selection. Our teens that are enrolling in Teen Club, they were already more likely to be adherent. And then they wanted to join this program just to have some sense of belonging. So we know that the 3 times likely, while a promising finding, is limited in its robustness, let's say. So that was a strong or a good limitation. So knowing that, now we're setting out to do more rigorous research, and we have a randomized control trial planned where that will really try to get at the effect of what we think is really quite a promising Teen Club program. So one of the questions that we continually struggle at, and I'd be interested if other panelists struggle with this too at Dignitas, is when to scale interventions. Do you wait until you've perfected the intervention and you have, beyond a reasonable doubt of its effectiveness, or do you push forward an intervention that you think is reasonably effective without, let's say, hard proof? And that's something that we continually go back and forth with at Dignitas on our Teen Club program and others. Knowing what we do and having conducted that retrospective analysis showing that Teen Club or teens that are in Teen Club are 3 times more likely to stay enrolled in care, we have scaled Teen Club. Out to 38 sites now, over 4,000 teens in 4 districts in Malawi. And now as we continue to scale it up, we'll continue to evaluate it. And what a scale up does is give us more sites so we can power studies more and push on getting really robust evidence. Because if we know something works, it's our job to scale it. And we need to scale it in customizable ways, and that's what we're trying to do at Dignitas. Maybe let me stop there and pass it over.
Perfect. Thank you very much, Josh. Appreciate. So thanks for sharing some of those challenges in terms of issues of disaggregated data and also how and when do you scale up. So our next speaker is Melanie Boyd. And Melanie has extensive experience in international development. And she has worked in international development for many years now, starting from the time of Canadian International Development Agency, now Global Affairs Canada, where during her 16 years there, she led program teams in Canada, Egypt, Afghanistan, and Kenya. And she also spearheaded key department-wide policy initiatives, including a cross-agency working group on human rights based approach, as well as the big Canada's investment of $3.5 billion in maternal, newborn, and child health. So she recently joined a nonprofit sector, so she's with World Vision Canada now, and she has also served before with Aga Khan Foundation in Afghanistan as the Director of Policy and Partnership, as well as Interim CEO. So today, Melanie will be sharing with us the lesson from adolescent health data in maternal and newborn health initiatives. So over to you.
You're going to think that Josh and I coordinated and rehearsed because I'm going to pick up on some of the same themes. But I think what is a bit different about the experience I'm going to share is that Born on Time, and this is the initiative that I'm currently program director for, is actually not an adolescent-focused initiative. It's actually a maternal and newborn health initiative. And so I think, as I was reflecting on some of the themes that have come out about data in the past day and a half, I think Born in Time is interesting because it illustrates, or it's an example of how you can use data to make the perspectives, the realities of adolescents visible inside a very large maternal and newborn health program. And that's quite an important thing to do. And I think it also illustrates very concretely challenges around disaggregation. And probably touches on your question about scale, because we actually went to scale from the beginning, and that's an interesting kind of thing to do. So just very briefly, to give you a sense of what Born in Time is about, and so that you see why maybe a maternal newborn health initiative is actually relevant to the discussion. Born on Time is focused on addressing the #1 killer of children under 5, which is currently preterm birth. And what's interesting about Born in Time is that we're prioritizing prevention. And since we're prioritizing prevention, it means that we start to look at a whole range of issues, and we're taking a very holistic approach. So we're particularly addressing key risk factors that we know are related to preterm birth, unhealthy lifestyles and behaviors, maternal infection, inadequate nutrition, and lack of contraception. So you can see already how that plays out into relevance to adolescents. We also have very strong focus on empowering women and adolescent girls and engaging men, boys, and community leaders. And we've talked a lot about this already in the past day and a half. I mean, the other thing I would like to say about Born in Time, and this is really speaking to the issue of scale and scope, is that Born on Time is fairly large in scope. We're a partnership of 3 international NGOs that are implementing. So it's Save the Children, World Vision, and also Plan International. And we have the support of Government of Canada and Johnson & Johnson. And so you have five large global players in this space. We are targeting 2 million beneficiaries, including 200,000 adolescent girls. And we're implementing in 3 different countries, very, very different contexts: Mali, Ethiopia, and Bangladesh. So that's created some challenges around harmonization of data collection, because we do have this philosophy around the importance of having some common frameworks across the 3 countries, because we think we can learn from that. So what do we want to know? Because there was a whole range of risk factors that we're looking at dealing with, we have a whole range of data needs or interests. And these range from, really understanding the experience of pregnancy, so antenatal care, delivery, postnatal care, the support of male partners. We also wanted to know something about what was happening at the health facility. What is the availability of health services, including adolescent-friendly sexual and reproductive health services? And what is the readiness of health facilities to actually deliver on that? We wanted to know about knowledge, attitudes, and practices related to sexual and reproductive health and contraception. And we importantly also wanted to know about power dynamics, decision-making within the household that might impact on health-seeking behaviors, on nutritional status of adolescent girls and women. We wanted to understand more about very unhealthy practices and behaviors such as intimate partner violence. So a wide range of data needs, and we wanted to understand all of that from a whole variety of perspectives. So we wanted to understand the perspectives of married women. We wanted to understand the perspectives of married adolescent girls, their partners, but we also wanted to understand the perspectives of community members and family members. So elders, elder women, religious leaders, a whole range. So you can already imagine how complicated our data collection exercise was. And as a result, we undertook a data collection process that involved a household survey, a health facility assessment, and a qualitative and gender equality assessment. So we faced early challenges, of course, and one of the key challenges was around disaggregation. We were very, very committed to distinguishing between the realities of adolescent married girls and married women. And we had this sense that there would be a different experience of pregnancy, for instance. We had expected that there might be different rates of antenatal care coverage. We thought that there might be different uptake around contraception. A whole range of issues we thought might be different. There would be a different experience. But what we realized once we started to actually put that aspiration into practice is that we didn't have the resources to do disaggregation. The sample sizes required to have statistically relevant results are very large, and we just simply couldn't afford to do disaggregation at that level. A second set of issues, and I won't go into all my bullets there, but they really relate to the second set of issues. Of course, we were wanting to know about some very sensitive issues. We were wanting to know about power relations, contraception, intimate partner violence, many things that are quite sensitive to talk about in any context at all. And what was interesting, because we're working in 3 different countries, is that the degree to which we could talk about those things varied between the 3 countries. And so it really impacted what we asked, who we asked it to, and most importantly, where and how we asked it. And so just as a quick example, it became apparent early on in discussion with our country teams that it would be very challenging to do a household survey that included unmarried adolescent girls in Bangladesh. So we had to think about other platforms. And this made our qualitative and gender equality assessment that much more important, because it helped us understand those perspectives that we couldn't understand through our fairly traditional tools. So very briefly, a few initial solutions. One very important thing that we did, and this probably speaks to the theme a little bit around empowerment, is that we developed early on a set of guidelines, and it was a set of guidelines for our enumerators and our country teams, really thinking about how to do gender-responsive data collection. And very prominently in that was guidance around how to ensure meaningful participation of women, girls, boys, and men, keeping in mind that they have very different perspectives, experiences, capabilities, and interests. And so really helping to sensitize our enumerators around that. How to create safe spaces for collection of data. So thinking about, was there availability of gender-sensitive wash facilities? Was there safe transportation? Was it a physically safe place? Was there sex disaggregated groups? So were girls being talked to separately from boys, women separately from men? And importantly, helping our enumerators think about things like respect for participants in these discussions, their own biases, and recognizing their own biases, and the importance of being non-judgmental. Many of the things we've already talked about during the conference. So that was a very important tool that had been developed early on. I think the second strategy was, and I've referenced this already, really, is the bringing together qualitative and quantitative methods and data sources. So not only does the qualitative assessment help us really understand and interpret our quantitative data, but it's a key piece of information that's going to inform our strategies around how we will empower or support the empowerment of women and adolescent girls. So that's a second very important strategy. A third one, and we're just experimenting with this one, is really kind of rethinking of our sample. So we had this aspiration, as I talked about, of being able to disaggregate between married women and married adolescent girls. Unfortunately, in the final sample, in many cases, we had very few married adolescent girls. So just to give an example, in Ethiopia, we had 905 women in our sample, if I include adolescent girls as women, but only 44 of them were adolescent girls. So this is very small, and it makes it very difficult to make statistically relevant conclusions. So we're looking right now at whether or not it's meaningful to include 20 and 21-year-olds as adolescents for the purposes of understanding experience of pregnancy for adolescent girls. And the reason why we think that might be meaningful is that we're asking 20 and 21-year-olds to recall their experience of pregnancy. So they often were pregnant adolescents. And so we think that we may have sufficient data to actually draw some more meaningful conclusions. So that's just a few of our initial solutions. I would say that our data journey is early days. So in fact, I think I'm going to take away a lot of the advice and ideas that have come through the conference, and we'll have to think about those some more and think about how we even, in a more meaningful way, deepen this idea of engagement and empowerment through data.
Perfect. Thanks. Thank you very much. So just if I may, probably, because I know we'll have questions at the end, but some of the key points that I'm keeping in mind from what you just presented in terms of addressing the health issues, look at the social determinants of health, because I think that's one point you've been emphasizing, as well as listening and engaging different stakeholders. You talked about different perspectives from the adolescent, but also the community members, which is really great. But also you highlighted the issue around resources when you really want to make sure that you have meaningful data. Mm-hmm. Where you can actually reach and engage the marginalized groups. And I think that has been a challenge, but thanks for also sharing some of the solutions that you've been putting together. So our next panelist is Dr. Haitam Kusa. He's from the Canadian Red Cross. So Haitam manages health recovery projects initiated by the Canadian Red Cross in countries affected by different kinds of disasters and crises. So he develops, advises, and supports specific programs, activities, targeting people affected by humanitarian crises with a special focus on reproductive, maternal, newborn, child, and adolescent health sector. So he's himself an active humanitarian worker and with a special interest in health, nutrition, in emergencies, health information system, topic of today, and disaster preparedness and response. And his work also brought him really in the field in Middle East and North Africa, and many trips also to conflict zones, including recently Syria and Palestine. So HealthM Talk today will focus on data collection for adolescent health in fragile settings with concrete examples from the field. So over to you, HealthM.
Thank you very much, Mary. Welcome, everybody, and thanks for attendance. I will try during a few minutes to highlight some issues we faced about data collections, processing, and utilization in fragile settings and during emergencies. Data collection is not an easy task, and even in regular times or stabilized situations. And we can imagine what happened in emergencies during conflict, wars, or after disasters when everything is collapsed. It's a big burden and a big issue we faced every day in our work. I have to admit, and I think most of you share, that adolescents' health topics during emergencies specifically still lay far down in the list of priorities of interventions during emergency phase specifically. And everybody went there during emergency phase focusing on children under 5 years old, women's maternal, pregnant, and lactating women. This is the main focus we see during emergencies, and focus on trauma and providing primary health care services for all people affected during crisis. I will try to highlight some issues we face during this process, which start and give some examples from the field as well. About access and availability of data. Sadly saying, in current time, we used to hear a terminology of besieged areas and hard-to-reach areas in current time. And those people who living there, we don't have any idea or clue about health indicators and in these areas. For example, in Syria, we support nutrition centers in Syria as Canadian Red Cross and with our partners, Syrian Arab Red Crescent. And when we try to reach population in these hard-to-reach areas and besieged areas, they give us a very tight window of 4 to 6 hours to deliver supplements. And when we go in, we don't have any chance to contact beneficiaries and how to teach people even to use these supplements and how to collect some data, to do some nutrition surveys about what's the situation inside these areas. We don't have any idea about what's going on. We just have time to unload trucks and go out. So there's no data available for us to do more work and to focus our interventions for certain topics or population. Also during emergencies, because of damage and destructions of many healthcare and medical facilities, we lost a lot of records and patient records and reports in these facilities. Sometimes also during emergencies, we have some social and cultural and barriers that prevent us from touching or asking some questions that they consider it as sensitive. For example, in Nepal, after the earthquake in 2015, we went there during emergency phase with a field hospital, and we discovered the issue of about the menstruation taboos against women in Nepal, in the west part of the country, where they isolate women outside the house. They are not allowed to touch food or water or cook during the period. And when we talk about partner in the country, about any robust data we can have and collect about this issue, they say, please don't touch that area. It's sensitive and it's long history, and we don't want to collect. And we say we don't want to change it. We just want to know about it, to collect data about the magnitude of this problem and issue. And there was actually a strong resistance and pushing back from even collecting data about this issue. And we ended up with a small community awareness session about menstrual hygiene we included in our intervention during phase. So sometimes there's many barriers that prevent us of collecting what we need, what the realistic needs from the ground. Also, we have an issue about different and wide variation of data collection tools, especially during emergency phase. During emergencies and after disasters hit certain country, everybody jumped to help. At national level, regional level, and international level, everybody sent their mobile teams, field hospitals, mobile medical clinics. Everybody jumped to the country to help. And everyone has their own health information system. They collect certain type of data. They use certain list of indicators. And there's wide variation that there's no inconsistent. There's inconsistent between data collected between different partners and actors on the ground. And this leads to missing a lot of data, specifically for groups like adolescents. And as I said at the beginning, again, the focus during emergency is toward children under 5 years old and maternal health. Fortunately, I have to share with you that WHO started working on this part, and we start seeing this in Nepal after the earthquake. They immediately send a health delegate who's sitting with the MOH officers there and coordinate the process of collecting data. They share a list of certain disease that everybody, all actors, all medical facilities on the ground have to collect and report on a weekly basis. So this is part of the solution. We hope this extends to include all the health information system during emergencies. Also, even to the standardization of level of data collections, when you talk about case definitions and alert threshold, when we talk about this should be standardized. No, when we see a Canadian Red Cross field hospitals working in that area using Canadian standardization and health information system, in other area, just a few kilometers away, we found a mobile health team supported by Japanese Red Cross, and they use Japanese standardization and criteria. So there's no standardization on the field during emergency, and this extends, unfortunately, during the recovery and development. When we start building projects during recovery and development, we use the same standardization, and we try to impose what we use in our countries. About accuracy of data and how accurate the data we collect, to which level we collect accurate data about adolescents or other health group sectors during emergencies. We have, during emergencies, especially after crisis and in conflict, we accept to collect data from sources that we don't use during regular time. We accept that level of data. It's low quality, but we accept and work with it. And we reach to the level in Syria, for example, to accept a fake data and put it in our record. And we know it's fake. And we know people are lying about their names and age. In our nutrition centers in Syria, people came and fake their names and ages because they are wanted and traced by other militia and groups, and they escape their areas to other areas, and they fake their names. And we know they said, we don't have any IDs to share, and they fake names and ages. And we put this, and we know they are lying. And you can imagine how it's difficult to follow up these cases and tackle those patients afterward. Also, we noticed something related to the data collected. Sometimes it's misleading. During work in these nutrition centers in Syria, we found that there's a high defaulter rate, reaching up to 60%. And when we dig deep in these numbers and figures in our reports, we found that those defaulters reach to the level they have green MWAC. They are normal, the kids are normal, or the mother are normal, and they self-discharge themselves from the program. They stop coming to program, and we lost tracking of those patients, and they consider them as defaulters rather than cured patients. So this kind of missing data leading to misleading interpretation and mislead the decision making afterward. Last point I would like to share about the hidden data. Sometimes we do some work targeting adolescent health, but it's gone unnoticed or unreported in a proper way. In Syria, just a few months ago, I visited a large IDP community in Aleppo city, and it's about 20,000 population. And when talking with our partner in SARC, they talked with me that we did a lot of community awareness session with this community, and this is the number of sessions. They showed me number of sessions and disaggregated number of participants, disaggregated by age and sex, and a lot of data. And I asked them what kind of topics you discussed during these awareness session. They said we talked about early pregnancy, we talked about early marriage, we talked about family planning, and they say why you don't highlight and what these? Yes, it's there. When you go to the far right in the Excel sheet, you find it under the topics discussed we found early marriage and early pregnancy. So it's there. They do some work to and tackling issues about adolescent health, but they don't report or document this in a proper way. They don't highlight the work we do for adolescents during the emergency time, because they believe that we're targeting families and parents. And this is session, yes, it's for parents, but it's tackling the issues about adolescents' health at the end. Also in our centers, we fall in the same dilemma of our centers focusing on treating malnourished cases of children under 5 and the pregnant and lactating women. But recently, because of dire situations on the ground, the staff there start seeing a lot of adolescents coming with malnourished cases, and that the staff there are not trained or don't have enough knowledge how to manage these cases, and they start calling us here in Ottawa, what should we do? And we contact with our partners in WHO office, and they help and educate people and staff how to manage these cases of adolescent malnutrition case, and we start reporting about it, by the way. After we faced many cases coming to centers, we start report those group of patients in a separate column. So the data during emergencies, during war, conflict, and after disasters is not an easy. It's not clear. It's not accurate. But it still give us a hint about the interventions we need to do, about the targeting group, and we should accept low quality and continue working to improve it. Thank you very much.
Thank you very much. Yeah. Thanks a lot, Haitham. And I mean, it's amazing to see how even little challenges that we see in regular settings, when they get really compounded when you're into the crisis. So thanks for highlighting that in terms of priority, coordination, standards, as well as quality of data in terms of accuracy, but also the prominency, because as you mentioned, some of the data is collected, but it's not visible enough. So thank you. So our last but not least panelist is Janani Vijayaragavan. I hope I pronounced it. If I didn't, please let me know. Yeah. So Janani is a health advisor at Plan International Canada, and she has been working in international public health since 2015. And her primary focus has been in maternal, newborn, and child health program implementation in South and East Africa, as well as Asia. So Janani provides technical support to Plan International Canada's health portfolio to improve the quality of programs and share best practices and learning from within the sector and provide capacity building support. And today, she will share with us the work of Plan International Canada in measuring gender-responsive, adolescent-friendly health services to improve Plan's international programming. So, Janani.
Thank you very much. So I'm going to speak a little bit about one of our health projects. It's a maternal and newborn child health program. It's called Strengthening Health Outcomes for Women, SHOW. I took out my overview slide, but the idea is that basically we're looking to increase the utilization of health services as well as the actual quality of services at health facilities. And there are a number of ways to measure and do baseline surveys to identify where you're starting at. So through household surveys, health facilities assessments, similar to what's happening with Born on Time. And one of the data collection methods that we've used more recently is a health facility survey, in which we looked a little bit more deeper because we would like to see, we're doing quite a few interventions around improving the adolescent friendliness of health facilities, trying to make them more gender responsive. And so we would like to measure them a little bit more to see what exactly does gender responsive adolescent friendly mean. So one of the things that we looked at were the development of two composite indicators. So we looking at the percentage of health facilities that provide gender-responsive, adolescent-friendly MNCH, SRH services, and the same indicator, but looking at it from the perspective of referral services. What we also did was look at the WHO's adolescent-friendly quality of care framework that speaks to making health facilities or the services for adolescents equitable, accessible, acceptable, appropriate, and effective. And within that framework, we looked at developing a set of criteria. So for the first indicator, we looked at a number of variables of what adolescents think is important for them to access services, because we know that there are a number of things that prevent adolescents from accessing when services are actually available, they don't access them, and there are a number of reasons for that. So we wanted to look at what were those criteria, both from the perspective of the adolescents, but also from the perspective of technical staff, global learning, WHO standards, bring it together and see if there was a way to weight all of this criteria based on how much of our intervention was addressing these criteria and what our technical group felt was most critical. And we assigned a score to these various criteria and then determined that if a facility met 50% of that criteria, then they would be considered meeting a standard or being considered as a gender responsive and adolescent friendly. So I'm just sharing a couple of criteria that we looked at for looking at gender responsive adolescent friendly services. So things like privacy is really important to provide adolescent services, or making sure that the services are free and subsidized, that there is actually somebody who's trained to provide an adolescent friendly service or provide a service that's also gender responsive. In many cases, adolescents want to be able to have convenient hours to go to the service, or to have a separate toilet for boys and girls, for men and women, boys and girls. And also, very often, a service provider may provide a service and not even ask for consent from an adolescent for that service, or explain that procedure, or really try to make them feel like what was coming next. So we looked at, these are just a sample of the criteria, and for the referral criteria, it's a mix of what should that service be to be of quality, what should it involve to be gender responsive, and what should it involve to be adolescent friendly. So things like follow-up, or asking to provide if they needed transportation services for referral. So these are just basic things that should be provided, but then you can also add on some layers and elements of being adolescent friendly and being gender responsive. So overall, when we looked at the two, the MNCH services indicator, but also the referral indicator, and again, the criteria is that the facilities had to score at least 50% to be considered to have met the standard. And we can see that for the most part, most of the facilities weren't able to meet all those criteria. Haiti, unfortunately, didn't meet any of the criteria in this setting. Bangladesh, Ghana, Nigeria, and Senegal, for the most part, none of them really met 50%. Some of them were close, but not really at 50. And when we look at referral, this is probably a combination. We see Bangladesh has been able to meet that standard, but the rest of the countries, not that much higher. So really this means that we did have a lot of criteria, so it's very difficult for a facility to have all the criteria and meet all of those, but even the priority ones are quite difficult to meet too. When we look more specifically, you can just pull out a few variables. So for example, if I just look at informed consent, specifically for adolescent girls, apart from Nigeria, not so much progress there, but it's also interesting because for both women and for adolescent girls, it's fairly similar. So basically, this seems to tell me that in the countries we're working in the health facilities we're working in, providers don't tend to ask for consent when doing a service, whether it's an adolescent girl or it's a woman of reproductive age. When we look at privacy, we looked more when it's privacy for providing a counseling service versus privacy for a checkup during pregnancy. I think the privacy for a checkup was much better than the service for a counseling related service. So this meant just having the availability of a screen, just to keep the distance from other people as a criteria that was really important to adolescents, and is a reason why many adolescents don't seek care. Anyway, so I guess in closing, really what I would like to just highlight is this methodology is just a way to look at health facilities a bit more deeply, to look at them by certain variables that you would identify as being important to providing adolescent services, gender responsive services. But also it's important because it's criteria that is often identified by adolescents, it's empowering for them to recognize that this is what they feel is important, but also you can dig a little deeper and share those specific details directly with adolescents at a higher level. So.
Great. Thank you so much. So this is very helpful, and actually probably talking about some of the double burden we heard when you're adolescent and you're a girl. So looking at the gender issue and consideration is critical, as well as also the issue around ethics that sometimes is overlooked. So thank you very much. We don't have much time left, so instead of probably just talking amongst ourselves, I will probably open up to the audience and have questions, comment, contribution. Please go ahead. We have 2 mics. One is there and the other one on the other side. And introduce yourself, and we will probably get 3, 4, and in order to maximize the time we have. And have the panelists address those. So please go ahead.
All right. Hi, my name is Bethla Kalilu, and I'm with the Conference Youth Council. Really enjoyed all your presentations. But I really wanted to know how long, in general, is the turnaround from research to application, and also how do you validate the time and engagement of your adolescent study participants? Thank you.
So please go ahead.
Thank you very much. My name is Jumana Haj Ahmed, and I work for UNICEF. Very interesting interventions. My question is relating to particularly what are we measuring, especially that the title of the session is Adolescent Empowerment. And with the examples that were provided, we're mainly measuring who is getting the service, the number who participated in various interventions. And I think when we look at empowerment, we need to look at the empowerment aspect of adolescence in terms of self-confidence, esteem, ability to make decisions, feeling empowered to participate in decisions. So my question is, how much is that aspect, or has that aspect being considered within your measurement frameworks? And a second quick question is on the gender-responsive adolescent health services. I would be interested to learn more about the differences between boys and girls when you structured your indicators and criteria. Thank you.
Thank you very much. I'm called Dr. Jennifer Twewaze, BRAC, Uganda. Thanks for the good presentation about the gender health responsiveness. And I think I like the issue of privacy. But following up on my colleague with empowerment, I was just wondering whether you have information about the providers, the sex of providers. When you talk about privacy, now this is a man with a young girl in a room. And I think we are having challenges back home of sexual harassment. How empowered can this young girl be to say no in the essence of privacy? We need both. I would like to learn more about this. Thank you.
Sure. And we have, I think, a last question on that side.
Hi, I'm Graham Dobson from McMaster University. I just wanted to ask a quick question with respect to the programs that the first 2 presenters discussed. Well, first of all, in the first program, with respect to youth AIDS prevalence on the rise, how do these weekend programs translate into final health outcomes, specifically transmission or harm reduction, as the intermediate outcomes you had spoken of, like follow-up adherence, necessarily translate into these final ones? I did most of my research in health program evaluation, and this can be very crucial for evaluating the cost of efficacy of a program with constrained resources, especially in a place like Malawi. So I just wanted to know something about that. Sure. Thanks.
Okay, so great. So yeah, if I may ask, I think you can start, Josh, addressing that question. Sure. And I think we have a couple of questions for Janan in terms of boys and girls, as well as the privacy issue, and the remaining 2 for data and use, as well as in terms of empowering adolescent, if I can have Melanie and Haitham address those.
Maybe let me quickly address your first question around the turnaround time between research to, let's say, research uptake and utilization of research. So that is ingrained within, I would hope, I think, all of our programs. It's definitely key to Dignitas's model. The short answer to that is too long. And maybe let me be a little bit provocative and say that one of the reasons it's too long, maybe two. One, research is complex, and we're not doing a good job as researchers to distilling down that complex research and making it accessible to key policymakers or let's say even other researchers in the field, so that we can utilize that research more quickly, whether that's to improve a program or to ask the next research question, which we can build upon. The second, and really what I see as our struggle in Malawi, is that we're really trying to balance the evaluation that is driven by donors. And in our case, it's often, let's say, USAID, and the data that we need to collect for them versus the data that we need to collect to improve our program. And we have teams of data collectors roaming Malawi in collecting what I would say is very similar data, maybe with slight differences, or the same data just on a shorter timeline than the national program. And I really worry about that and think we maybe have pushed the pendulum too far to having donors drive the research agenda. And I understand that. And I understand their push for impact. But that really is causing a lot of duplication in the system and undercutting these national, let's say monitoring evaluation or health systems, HMIS programs that we really should be strengthening, not duplicating. Maybe let me just end that question.
Maybe I'll talk to two questions. Yes. So this point about validation. So I'm not a researcher, but maybe I could talk about it in the context of the baseline assessment that we did as being a piece of research in essence. And 2 points there. One is I would agree that it takes a long time, longer than maybe ought, but if you're thinking about the importance of the accuracy of your data, and maybe that does depend on how you're going to use it and the context that you're working in. But if you're thinking about the potential for your data to actually inform a practice gap or an evidence gap, then accuracy actually is important, and you do need to invest in making sure that the data is cleaned, validated. The second thing I would say about that, though, is that typically when we're doing these things, we're using that data to set targets around performance, and we're not doing that in isolation. So in the context of Born in Time, that process of looking at even initial data and target setting was done in close collaboration with government and other stakeholders. And that process of looking at, okay, well, the data that we actually generated, even if it's not completely cleaned yet, but this initial data looks different than the data that's coming out of your health system, health management information system. That actually creates and generates a very interesting conversation. So I think there's that opportunity that's there. On the question about what are we measuring, I think that's really important. And I didn't really have the time to highlight sufficiently the piece of work we did around the qualitative and gender equality assessment, because I think that's where you start to ask really important questions, or you're able to ask really important questions around decision making. So we did actually spend quite a lot of time exploring with unmarried adolescent girls and boys, married adolescents, how decision making works, who decides around access to health services, how does it work inside the family, who decides around use of contraception. So I think that's where, even when we're using maybe fairly traditional data collection methods, where you can really start to ask some of the very, very important questions that you're talking about.
Yeah, I would like to just to answer the question about what data we collect for. Honestly, we still focusing on quantitative. We have, you can say, almost nothing about qualitative data. There's many constraints, especially during emergencies and in conflict and crisis time. But we do include a certain intervention in Syria now. We support 6 nutrition centers. In each center, we have a mobile team of adolescents, volunteers, who doing community surveys, visiting door-to-door houses and doing measurements, MWAC measurements for children and women in this. And this group of 10 volunteers with a team leader doing this on daily basis. And those group of volunteers, adolescent volunteers who discover the issue about adolescents malnourished cases, and they refer them to the centers. And this kind, I think, it's of empowerment of adolescents' health through engaging them in the data collection process from the beginning.
And maybe very
Yes,
quickly,
go
I
ahead,
can just speak
Janan.
to a couple points. On the question about empowerment of adolescents and how we're actually getting or measuring any sort of data on that, we do have, within our baseline household surveys, there is a component around decision making, which we are also integrating into gender assessments. And we're looking at the percentage of, in our sample, women of reproductive age who report participation in leadership positions or ability to make decisions around their own health, their ability to choose contraception. But just to point out, this is in the context of a maternal newborn health project in which adolescents are part of the target, and in which, similar to what Melanie raised, being able to sample adolescents in a women of reproductive health sample, we don't often end up with as many representative adolescents as we would like. So the data is not always, it's not great for getting a sense of exactly what the adolescents are compared to the overall women of reproductive age. But we do get a sense of where they sit in terms of being able to make decisions for themselves. And I think that continues to be a gap. The data that I was showing was actually based on a health facility questionnaire. So questions that were asked at the health facility to providers at the health facility. And so in terms of empowerment at that level of adolescents, it's more from the perspective of the provider. And then related to the privacy issue and the impact of having a male provider for a female adolescent or vice versa, it is a huge issue, and it is also another barrier that is part of the scoring of the number of criteria that we looked at. And for facilities that we work in, at the level that we work in, having a trained provider who is male and a trained provider who's female is very unlikely, because in all likelihood, there's one person who does antenatal care, postnatal care, adolescent-friendly services, everything, and it's always one person. So we recognize that it's unlikely to happen, but it is, so most facilities would probably score poorly on that, that particular criteria, but is again a huge barrier for why a female adolescent may not wish to seek services, and also a barrier for why, for example, in Bangladesh, why women don't want to go to a male provider for antenatal care. So it's consistent for both adolescents and women of reproductive age. So. And maybe I can speak to you a little bit more about the boys and girls in care.
Sure, yes. So I know, apologies, because we're almost already 10 minutes beyond our allocated time. So probably we'll end here, and I would like to thank all the panelists, and thank you all. And there is a lot to think about, to follow up. We're talking mainly about that balance, I think, early between having accurate, complete information, evidence, and the time to actually act on the information and use it and inform our programs and policies. So there is a balance on how far you can go to really get the best data you want, but also what can you use in the meantime in order to inform what we're doing. So I guess that's overall the key message from this session. So thank you very much, and please join me in thanking our 4 panelists. Thank you.